Bismillahir Rahmanir Rahim. And Allah says in Holy Quran, indeed, Allah will not change the condition of a people until they change what is in themselves. The topic for today's presentation is cytomegalovirus. I am Dr. Ayesha Amin, PGR of FCPS Community Medicine at Institute of Public Health, and I will be presenting this under the kind supervision of my professor and teacher, Professor Dr. Saira Afzal, who is the Dean of IPH Lahore. The learning outlines for today's presentation would be introduction, epidemiological triad of CMV, chain of transmission, clinical stages, management and prevention, epidemiology, CMV in pregnancy, congenital CMV, recent updates, and multiple choice questions. The learning outcome. At the end of this presentation, the participant would be able to describe about cytomegalovirus, its epidemiological triad, chain of transmission, clinical stages, congenital CMV, the level of preventions, and to be able to answer the MCQs. Introduction. Cytomegalovirus is a common double-stranded DNA virus belonging to herpes viridae family. Cytomegalovirus is also known as heterophile negative mononucleosis. It is widely prevalent worldwide and establishes lifelong latent infection after primary exposure. Most infections are asymptomatic in immunocompetent individuals, but CMV can cause severe disease in immunocompromised patients and is a major cause of congenital infections. From a public health perspective, CMV is important due to its role in congenital CMV infections, which is a leading infectious cause of sensory neural hearing loss, neurodevelopmental delay, and congenital anomalies in children. The epidemiological triad, consisting of host, agent, and environmental factors. Agent factors. The causative agent is cytomegalovirus, which belongs to the beta herpes virus family of herpes viridae. The genome, it is a double-stranded DNA virus which is enveloped, and the characteristic feature of CMV virus is the presence of intranuclear inclusion bodies. It has a property of latency and reactivation of later in life. It is heat labile and it is inactivated by disinfectants and drying. The host factor. Age. The extremes of age, especially the neonates, are affected for congenital infections. Immune status. The immunocompromised individuals, such as the patients of HIV and AIDS, the transplant patients, chemotherapy patients. Pregnancy. Primary cytomegalovirus infection in pregnancy increases the risk of congenital CMV. Then lack of prior immunity, close contact exposure, such as healthcare workers and the people of daycare, and breastfeeding infant if the mother is actively shedding the virus. The environmental factors: overcrowding, poor hygiene practices, daycare centers and nurseries, low socioeconomic conditions, limited access to screening in pregnancy, inadequate infection control in healthcare setting, and the unsafe blood transfusion or organ transplant practices. The source of infection. Almost all body fluids are the active source of infection of cytomegalovirus, including saliva, urine, semen, blood, and breast milk. Modes of transmission. The cytomegalovirus is transmitted by saliva due to kissing, sexual contact, placental transfer. There is also transfer due to breastfeeding, then due to blood transfusion, solid organ transplantation, and hematopoietic stem cell transplantation. The incubation period of the virus is almost 4 to 8 weeks. The clinical features. The acquired cytomegalovirus infection in immunocompetent individual is often asymptomatic, but it can produce the mononucleosis like illness such as prolonged fever, malaise, fatigue, myalgia, and lymphadenopathy. There is hepatitis, but the distinguished feature from Epstein-Barr virus, which is also known as infectious mononucleosis or the positive heterophile mononucleosis, is that in cytomegalovirus there is no or minimal pharyngitis. The cytomegalovirus infection in immunocompromised patients is often severe and life-threatening. It can lead to CMV retinitis, which includes blood vision and blindness, pneumonitis, which leads to cough and dyspnea, then esophagitis, which with the symptoms of odynophagia and dysphagia. There is colitis, which causes diarrhea, abdominal pain, and bleeding. There is hepatitis, encephalitis, and bone marrow suppression. The complications of CMV in immunocompetent adults again are rare, but it can lead to prolonged fatigue, chronic hepatitis, and thrombocytopenia, while the complications are more common in transplant or patients with transplant and immunocompromised individual. The transplant-related complications are graft rejection or dysfunction. There is increased risk of opportunistic infection. There are chronic allograft injuries, and there is increased post-transplant morbidity and mortality. The complication in immunocompromised individual is again CMV retinitis, which leads to irreversible blindness. There is CMV pneumonitis, CMV encephalitis, CMV colitis, and CMV esophagitis. There is hepatitis and bone marrow suppression leading to anemia, leukopenia, and thrombocytopenia. There is a suppression of the all three cell lines, and it ultimately leads to multi-organ failure. The diagnosis of CMV is usually made on the PCR for CMV DNA, which is the most specific and sensitive test. The urine or saliva PCR within the first 3 weeks of the life is the gold standard in case of congenital CMV infection. The other serological test includes IgM antibodies, which shows recent or primary infection, while the IgG antibodies, it shows the past exposure. The histopathology shows the typical owl eye intranuclear inclusion in tissue biopsies, which is the characteristics of CMV infection. The viral culture is confirmatory, but is slow and it is rarely used now. So this is the picture again, which is showing the histopathological feature of the CMV virus, which is the characteristic owl eye appearance of which are basically the intranuclear inclusions. So the treatment of CMV, no treatment is needed in asymptomatic immunocompetent individual, while IV genciclovir or oral valgenciclovir are the drug of choice in case of immunocompromised individual. The treatment is indicated in the symptomatic congenital CMV and immunocompromised patient. The foscarnet or cidofovir are also used for drug-resistant CMV. Then there is mainly supportive care and long-term follow-up is needed for hearing loss, vision, and development are essential. So we need to monitor the cytomegalovirus load or antigenemia once weekly while on therapy. Generally, the treatment it is continued until the virus is undetectable in the serum. It may consider a 1 to 3 month course of secondary prophylaxis after the completion of the primary treatment. Individual with the CMV retinitis commonly requires surgical intervention, whether for the repair of a retinal detachment or for intravitreal installation of ganciclovir with the help of an injection. So the most important part is the CMV infection in pregnancy. So the vertical transmission of the cytomegalovirus may occur because of the transplacental infection after primary or secondary infection of the mother, exposure to the contaminated genital tract secretions at delivery or even at breastfeeding. The transplacental CMV transmission represent the most significant risk of developing clinical sequel. The cytomegalovirus infection resulting from exposure to the infected cervical secretions or breast milk is typically asymptomatic. It is not associated with severe neonatal sequel. With primary maternal CMV infection, the overall risk of transmission to the fetus is approximately 30 to 40%. Transmission rate for primary infections are 30% in the first trimester, 34 to 38% in second trimester, and 40 to 72% in the third trimester. So the greatest chances of transplacental transmission of the CMV are highest in third trimester. The vertical transmission after a recurrent infection is approximately 0.515 to 2%. Infants infected after maternal CMV reactivation generally are asymptomatic at birth. Congenital hearing loss is typically the most severe sequel of secondary infection, and congenital infections after recurrent infection, they are unlikely to produce severe sequel. So, as we all know, this congenital cytomegalovirus is one of the torch infection that affects that can affect the mother during pregnancy. So, the torch in T is basically stands for the cytomegalovirus infection during pregnancy. So the women with the in cytomegalovirus infection in pregnancy, again, the patients, they are usually the immunocompetent patients. They are usually asymptomatic, but a pregnant woman can be in an immunocompromised state. It can present with mononucleosis-like syndrome, fever, chills, myalgias, malaise, leukocytosis, lymphomatosis, again, abnormal liver function or lymphadenopathy. So, screening for mothers, the routine serological screening of the pregnant women for CMV is not recommended. The vast majority, approximately 90% of the positive IgM results are false positive. The limitation of maternal IgM antibody screening test in differentiating primary from recurrent infection also makes the results difficult because the IgM, it does not necessarily tells that the infection is primary or it is a recurrent infection. So maternal immunity, it does not eliminate the possibility of fetal infection, and the lack of vaccine for prevention or a proven treatment to prevent congenital transmission further diminishes the potential benefit of universal screening. So the screening is not recommended. The diagnosis and management of the CMV in pregnancy can the CMV, it can be detected in the amniotic fluid of the infected fetuses by either culture or PCR. The sensitivity of CMV amniotic fluid culture, it ranges from 70 to 80% compared with the sensitivity of 78 to 98% for the PCR. So currently, no therapies are approved by the Food and Drug Administration (FDA) for the treatment of maternal or fetal CMV infection. In case of known maternal CMV infection, referral to the maternal fetal medicine or infectious disease specialist with expertise in pregnancy management may be warranted. And serial ultrasonographic surveillance that includes the assessment of fetal anatomy, that is, especially the cerebral ventricles and growth, is performed. This is a case presentation in which a 4-month-old baby, a girl, presented with the complaints of vomiting, diarrhea, and body contractions. It was reported that the girl had been vomiting whatever she had eaten 3 to 4 times per day, having watery diarrhea 2 to 3 times per day in the previous weeks. Moreover, for the last 3 days, she has experienced a few seconds of contraction in her arms 3 to 4 times per day. The parents were found to have first-degree consanguinity, and the mother had history of cesarean delivery. The patient had microcephaly with the long eyelashes, an upturned nose, highly arched palate, retrognathia, distinctive ears, and a short neck. She had medical deviation of the she had medial deviation of the second finger, agenesis of the middle finger, and syndactyly for the fourth and fifth fingers of the right foot. Moreover, she had irregular foot lines. The bilateral chorioretinitis was determined at the ophthalmological examination. The patient had impaired neuromotor development and had no control of her neck and head. The serological test shows the hepatitis markers are negative, or all the hepatitis C, B, and viral markers were negative. The toxoplasmosis, Epstein-Barr virus, herpes simplex virus type 1 and 2, rubella, parvovirus B19, and HIV serological test all were negative. The serum cytomegalovirus IgM was positive, IgG was positive, and urine CMV DNA PCR was 3,303 million copies per ml. The mother's serum CMV IgM was negative and IgG was positive. So it was basically a case of the congenital cytomegalovirus infection in the baby. So what is a congenital cytomegalovirus infection? When a baby is born with cytomegalovirus infection, it is called as congenital CMV. It is defined as the isolation of CMV from saliva or urine within the 3 weeks of birth. The commonest congenital viral infection affects 0.3 to 1% of all live birth. The second most common cause of mental handicap after Down syndrome is cytomegalovirus, and it is responsible for more cases of congenital damage than rubella. In CMV infected neonates, only 10 to 15% of newborns are symptomatic at birth, and the serious complications can occur later in life. The clinical feature: some babies with congenital CMV infection have signs at birth such as rash, jaundice, microcephaly, low birth weight, hepatosplenomegaly, seizures, and retinitis. The long-term complication or consequences of CMV, congenital CMV, is hearing loss, which is the most important and most common complication of CMV infection, developmental and motor delay, vision loss, microcephaly, lack of coordination or weakness, seizure, and in most severe cases, CMV can even cause pregnancy loss in the mother. Coming to the prevention, the primary prevention, which focuses on health promotion and specific protection. The health promotion includes good hand hygiene, especially after contact with urine or saliva. For example, after kissing the children's, avoid sharing utensils, cups, toothbrushes with young children and even with adults. Safe sexual practices, health education for pregnant women, and universal infection control practices in healthcare setting. Specific protection. Currently, there is no licensed vaccine is available for CMV infection. There is a candidate of live attenuated vaccine known as Townstain, but there are concerns about administering a live vaccine, which could become latent and reactivates. Prevention of cytomegalovirus disease in transplant recipient is a very complicated subject and varies from center to center. It may include the following measure. So, screening and matching the cytomegalovirus status of the donor and recipient, use of cytomegalovirus negative blood for transfusion, administration of cytomegalovirus immunoglobulins to seronegative recipient prior to transplants, and give antiviral agents such as acyclovir and ganciclovir in prophylaxis. The secondary prevention includes the screening of blood donor and use of CMV negative or leukocyte reduced blood products, antenatal screening. As we already started that the screening is not recommended, but in case of high risk pregnancies, we can go for the screening. Early diagnosis using PCR, especially in neonates and immunocompromised patients, and cytomegalovirus can be transmitted through breastfeeding. So it is necessary to start antiviral for the mother, and breastfeeding it should be discontinued. Tertiary prevention. The antiviral prophylaxis are preventive therapy in transplant recipient. Early treatment to prevent complication and sequel, hearing or in developmental follow-up in infants with congenital CMV, and rehabilitation for neurological and sensory impairments. Epidemiology. The CMV is a common virus that infects people of all ages. In the United States, nearly 1 in 3 children is already infected with CMV by age 5. Over half of adults have been infected with CMV by age 40. About 1 in 200 babies are born with congenital CMV. About 1 in 5 baby with congenital CMV will have birth defect or long-term health problem like hearing loss. Young children are a common source of CMV. By 5-year-old, 1 in 3 children has been infected with CMV, but they usually do not have any symptoms. Unfortunately, we don't have the data for CMV in Pakistan. Recent updates. So, management of cytomegalovirus infections in the era of novel antiviral players, Lettermover and Mary Beber. This is the study which was published in 2024. And it says that cytomegalo infection may increase morbidity and mortality in immunocompromised patients. Until recently, standard antiviral drug against CMV were limited to viral DNA polymerase inhibitor that were ganciclovir, foscarnet, and cidofovir, which with the risk of cross resistance. These drugs may also cause serious side effects. So, in this review, they found out that the Lettermover was approved in 2017 for CMV prophylaxis in CMV seropositive adults who received allogenic hematopoietic stem cell transplant, and Mary Bever followed 4 years later with an indication in the treatment of adult and pediatric transplant patient with refractory or resistant CMV disease. So Lettermover prevents the cleavage of viral DNA, its packaging into capsid, and Mary Bever is basically a PUL97 kinase inhibitor. So the both drugs have activity against most CMV strain, which are resistant to the standard drug and exhibit favorable safety profiles. So they are the better option for the treatment of CMV infection in the transplant patients. The other article says that the congenital cytomegalovirus and hearing loss, the state of the art. So, in this article, they stated that there are many controversies regarding the preventive, diagnostic, and the therapeutic approach to the congenital CMV infection. Hearing loss secondary to congenital cytomegalovirus is highly variable in onset, site, degree, audiometric configuration, and threshold changes over time. Therefore, it is of paramount importance to perform a long and thorough audiological follow-up in children with CCVM infection to ensure early identification and prompt treatment of progressive or late onset hearing loss. Earlier cochlear implants, they appears to be a valid solution not only for the children with bilateral profound hearing loss, but also in children who has a single-sided hearing loss or deafness. So coming to the multiple choice questions, the first MCQ is a 28-year-old preemie gravida presents at 18 week of gestation with mild fever and malaise. Serologic shows the CMV IgM positive and low IgG avidity. What is the most appropriate next step to assess fetal infection? A, chordosynthesis for CMV culture, B, ultrasound only, C, amniotic fluid CMV PCR after 20th week, neonatal urine PCR, and repeat IgM after 4 weeks.
D.
The right answer is C. The amniotic fluid test is performed in case of CMV infection in pregnancy. A newborn presents with petechia, jaundice, hepatosplenomegaly, and microcephaly. Which investigation will best confirm the congenital CMV infection? A. CMV IgG in serum, CMV IgM in serum, C. Blood culture, D. PCR of urine within 3 weeks of life, and E. Liver biopsy.
D.
Yes, D is the right answer. The recommended time is PCR of urine. The CMV, congenital CMV, is labeled when the patient has an infection which is diagnosed within the 3 weeks of the life. So, a daycare worker developed prolonged fever and malaise. She had no pharyngitis. Lab tests show atypical lymphocytes. Which feature help differentiate CMV from EBV infection, that is Epstein-Barr virus infection? A. Absence of pharyngitis. B. Atypical lymphocytes. C. Splenomegaly. D. Positive heterophile antibody test. And E. Lymphadenopathy.
A.
Yes, A is the right answer. The characteristic difference between the CMV and EBV infection is in CMV, the pharyngitis is absent. And the fourth MCQ is a national maternal health program consider routine CMV screening in pregnancy. The main public health limitation of universal screening is A, low prevalence, B, lack of sensitive tests, C, lack of vertical transmission, D, high mortality, E, absence of effective vaccine and definitive prenatal treatment.
A.
No, the right answer is E, as we know that there is no recommended vaccine available currently for a CMV infection, and also there is no guideline for the treatment of CMV infection in pregnancy. So, due to the lack of effective vaccine and definitive prenatal treatment, the universal screening is not recommended. Which preventive intervention would be most cost effective to reduce the congenital CMV in low resource setting? A, universal antiviral prophylaxis. D, routine CMV PCR in pregnancy. E, health education on hand. C, health education on hand hygiene. D, universal cesarean delivery. E, neonatal vaccination.
C.
Yes, C is
A.
the right answer. The C is the right answer. Health education on hand hygiene. So we need to basically break the chain of transmission, and we need to follow the strict infection control practices. So we will educate the patient or the general community on hand hygiene. During an outbreak investigation, CMV transmission is suspected in a neonatal ICU. Which control measures should be prioritized? A, antibiotic prophylaxis. B, strict hand hygiene and contact precautions. C, isolation of all mothers.
Beta.
D, closure of ICU. C, routine antiviral therapy for staff.
B.
Yes, B is the right answer. Again, strict hand hygiene and contact precautions. The seventh MCQ is a policymaker asks why congenital CMV is underreported compared to rubella. The most valid reason is A, lower transmissibility, B, lack of awareness and routine screening, C, lower severity, D, short incubation period, E, absence of vertical transmission.
B.
Yes, B is the right answer. Eighth MCQ, National Maternal Health Committee data debates routine CMV screening during pregnancy. Which factor weighs most against universal screening? A, high prevalence, B, high sensitivity of PCR, C, absence of definitive prenatal intervention, D, high vertical transmission, E, high case fatality.
C.
Yes, again, the right answer is C, because of the absence of definitive prenatal intervention. Uh, The ninth MCQ as district surveillance officer notes an increasing number of infants with sensory neural hearing loss. TOT screening shows CMV as the most frequent infection. Which public health action should be prioritized? A, mass antiviral prophylaxis for neonates. B, universal CMV vaccination. C, health education for pregnant women and hygiene. D, routine cesarean section for all CMV positive mothers. D, E, mandatory isolation of CMV positive mothers.
C.
E.
Yes, C is the right answer. The last MCQ is a 35-year-old HIV patient with CD4 count of 40 cells per microliter presents with the chronic diarrhea and abdominal pain. Colonoscopy show large shallow ulcers. The most likely etiological agent is A, Cryptosporidium, B, Entamoeba septica, C. Clostridium difficile, C. CMV, D. Isospora belli.
D.
Yes, the most common cause of infection in transplant or immunocompromised patient is CMV. This is the key to all the MCQs. These are the references which have been used in the presentation. This is the official channel of the Institute of Public Health where the recording of this presentation will be uploaded. And thank you for your attention.
Thank you so much. It was a very informative presentation.
Thank you, Dr. Amna.